Good evening, all. It is my honor to be hosting today's talk organized by Satva Charitable Trust. As homeopaths, we are well aware that the prescription of sarcodes and nosodes on the basis of materia medica is very difficult. Hence, in order to understand them, a clinical approach is required. We have Dr. Kanika Sabharwal, who will guide us through her journey of treating infertility with the SARCODE folliculinum. Dr. Kanika Sabharwal is an alumni of CMP Homeopathic Medical College and is an assistant professor in the Department of Obstetrics and Gynecology at her alma mater since 6 years. She was a gold medalist at the MD entrance exams, after which she pursued her MD in Pediatrics. Women and child healthcare is the focus of her practice and research. She has presented at international conferences such as Homeopathic Research Institute London, Ayush International Conference Dubai, and International Developmental Pediatrics Association Congress Mumbai. She has peer-reviewed articles published in indexed journals on infertility, menorrhagia, psoriasis, etc., including 6 ebooks being published. I request ma'am to now take us into a deeper understanding of today's topic.
Good evening, everyone. Thank you, Shreya, for your kind introduction, and nice to see some familiar names in those attending and some new people as well. So first and foremost, thanks for spending your Sunday evening for a medical discussion. Let us begin. If you give me a minute, I'll just share my screen. All right. Can you see my screen?
Yes, ma'am.
Yeah, is the screen visible to everyone? May I begin? Yes, all right. Perfect. So as the name suggests, today's session is going to be, we're going to cover both aspects of our topic. First and foremost, we're going to run through a little bit of the understanding of the SARCODE folliculinum. And the second aspect is we're going to try and understand why we talk about its role so much in infertility. So let me just begin with one of my favorite quotes by William Osler, where he says, "He who studies medicine without books sails an uncharted sea, but he and she who studies medicine without patience does not go to sea at all." And the reason I like this quote so much is because even though I'm a teacher at a medical college, I truly believe that when we see patients and when we apply our knowledge clinically, that's when we add on to it. That's when we discover that not everything that we've seen in theory works 100%. We need to evolve ourselves. So that is how this protocol came about to be. That's what I'm going to discuss with you today. Before I begin, let us have a quick recap of the 3 terminologies that are sometimes used as synonyms, but they're not synonyms. So let's just understand a quick difference between them. First, we have fecundity. Fecundity simply refers to the probability to achieve pregnancy in a single menstrual cycle, assuming both partners are healthy. Then we have infertility itself, which is the textbook definition that everyone's familiar with. The inability to conceive despite regular and unprotected coitus for approximately 12 months. And the third one, which is sterility, there's a little bit of a gray area here because sterility technically means an irreversible cause of infertility. But in our homeopathic literature, the word sterility is actually used instead of infertility. So if you were to study sepia from materia medica, or if you were to open a repertory and look for the rubric infertility, the cross-reference given to you would be sterility. So this is something that we should just keep in mind. Let us understand which of these 3...
Hello, Dr. Kanika.
Yes?
Your slides are not changing.
Okay, one second. Yeah. Should I redo it? Can you see the slide now, which says terminologies?
Yeah. This one is visible.
Okay. And now the one which says fecundity?
No. It's not changing, I think. So you share your entire screen rather than now it is changing.
Okay. Now?
Yeah, it is
Okay.
Fecundity.
Yeah, that's right. Okay. Thank you. So as I was saying, fecundity basically refers to the probability of conceiving in a single menstrual cycle, and assuming both partners are healthy, still an average couple has only 20% chance per cycle. And going by this statistic, we have to wait about 13 months, and in that interim, 95% of couples should conceive naturally. And this statistic is where your definition comes from, where they say wait for 12 months of regular unprotected coitus. Now, if fecundity is a natural phenomena, do we really feel that, we need to treat it? And if yes, is there any role of homeopathy? In my opinion, we can treat such patients simply because of two reasons. Because today what we see is there is slightly delayed age of marriage. First pregnancy is postponed. People start family planning in their mid-30s, and then the anxiety and the urgency comes up because the female partner feels she's running against a biological clock. The anxiety element adds in. So as regards those aspects, we should and we can treat homeopathically, and our constitutional remedy happens to be the best to boost fecundity. We've had a lot of patients who've come to us for difficulty to conceive and infertility, and within just 1 to 2 months of adding the constitutional remedy, we find that they get a positive result. The next topic that we discuss is infertility, which all of you are familiar of two types, primary as well as secondary. And this is the arena that we tackle day in and day out in clinic. These are the patients that have infertility because of PCOS, because of endometriosis, various uterine, tubal, ovarian pathologies. And this is the category of patients where our medicine has the most scope, and usually this is the curable category. The third one is sterility, as I mentioned earlier, which refers to certain anatomic or congenital anomalies which are irreversible. In the male partner, we may have undescended testes or Carter-Jenner syndrome. In the female partner, we have conditions such as hypoplastic or infantile uterus and primary or premature ovarian failure. In this category, of course, our scope is slightly restricted, and if it's a case of undescended testes, in my opinion, the patient needs a surgery and surgical correction. But we have had 1 or 2 cases where hypoplastic uterus has improved after homeopathic prescription. The ovarian failure and the AMH level has improved after treatment. So in this category, I would say while it's restricted scope, there are some instances, like they say, miracles can happen at any point. But I would just like to caution you that, remember, when you use the word miracle, you're talking about something that happens once in a way. So as a young practitioner, we also shouldn't have false confidence where we think, oh, we can treat everything with homeopathy. These cases are restricted. So with this short introduction, let us move on to female causes of infertility and integrate to Which slide can you see at the moment, Yarish? So in slideshow, it's not changing. Can I keep it like this so that you don't miss out? Is that all right? Can everybody see clearly if I leave it without the slideshow mode? Would that be all right?
Yeah, it would be all right. Only thing is you maximize the visibility, maximize to 70-80%. Without slide share.
Yeah, is this all right? Is this okay? Can everybody see the screen, and is it enough visibility for you to read?
No, you'll have to share the slide, but don't run the presentation. You share the entire screen. Rather than only the PowerPoint, you share the entire screen.
Yeah, that's what I've done, Dr. Rakesh. Now is it all right?
Yeah, down there is a percentage of visualization.
Yeah.
So that you can increase, thoda.
Yeah, I've done that to 100%.
Okay. Okay. That's fine.
Yes, everybody, is it okay for you all to read?
Yes, ma'am.
Okay, perfect. Sorry about that. So let's now move towards causes of female infertility and how we integrate and thought of folliculinum for this particular condition. As you see here, ovarian causes contribute for 30 to 40% causes of female infertility, which is the largest and most common cause. These include conditions such as dysovulation, that is ovulatory dysfunction, anovulatory cycles, which we see in PCOD day in and day out, and corpus luteum insufficiency. In fact, if you refer to the ICD-10 classification, you will see that the sub-classification, the first point that they have mentioned is female infertility associated with anovulation. And I think most of you here, if you've attended a gynac OPD, you've definitely come across that this PCOD with anovulatory cycles remains the most common complaint presenting to the OPD today. And with homeopathic medicine, we have excellent scope to reverse this, eliminating or minimizing the role of hormonal pills and ovulation induction drugs. What is our approach in cases of infertility? Nothing different. It's what you've learned in medical school. It's what all of you are executing. First, take a detailed history. And when you talk about infertility, it goes without saying that you will be interviewing both partners, followed by examination. Now, here you will see that I have put advice before investigations and treatment. And the reason for that is because once you've diagnosed the underlying cause for the infertility, it's our duty and it's often the requirement where we first give the patients advice as to what the diagnosis is, what the prognosis is, and then we talk a little bit about how we can manage it with homeopathy. So usually this discussion and the counseling tends to come up even before you've gone into suggesting investigations and treatment, when you're almost sure of the underlying cause of their infertility. Now I'd like to run you through my approach for cases of infertility. Just let me know in case there's an issue with the slide. Can you see the slide that says homeopathic approach, everyone?
Yes, we can, ma'am.
Okay. So first and foremost, we look for diagnosis, and as you've been taught in homeopathy, finding out the cause and tracing the cause remains the most important. Here I'm referring to cause at the structural level, that is an organic pathology, and if there is a psychodynamic or a cause that is resulting from any disturbance at the level of mind. Once you're sure with that and you've determined that there is an organic pathology, you need to further decide whether that pathology is something that you can treat and that it is reversible. If it is irreversible and incurable and you feel there's no role, immediately sit them down, counsel them, and refer them for ART, that is assisted reproductive techniques, which includes IUI, IVF, surrogacy or adoption, depending on what will suit the couple. If you feel that it is treatable, you have two options. You can either go with pure homeopathy, which is the preferred option, but in some cases, you may require to go for an integrated approach where you also involve a gynecologist. The next group is where you've determined that there's no organic pathology, the reports have come back normal, both partners are healthy. Definitely we have good scope here. Again, here we hold off on treatment. We see if we need homeopathy or if just by counseling and reassurance, they can be helped. Now, this last category typically you will see in patients where the anxiety level is more, where they've just started family planning, it's just been a couple of months and someone in their extended family or friend circle got pregnant immediately after trying, and that comparison comes in. So they come to you saying, doctor, they got married 1 month after us and our friends are pregnant, but why hasn't it happened for us? And things like that. But when you go through the history, you find that both partners are healthy, her cycles are regular, on time, moderate flow. There's really nothing that could suggest that they would have a problem. So you counsel them, you reassure them, you explain to them your definition, why they need to wait for a few months, and you may hold off on your remedy as well. So when we speak about homeopathic medicine, what are the different treatment modalities that we have with us? First and foremost, as you see, the largest block belongs to the constitutional medicine because that's what's going to help us in majority of our cases. We also intersperse it with anti-miasmatic remedies depending on the case and the dominant miasm. And in some cases, we intersperse with remedies that are called specific remedies or organ remedies. And this is what I'm going to demonstrate for you today. All right. Before we go into the details of folliculinum, just quick word of advice from my experience treating infertility. Like I said before, determine the scope and prognosis because patients always want to know when they can expect to get a result. Whilst we can't give them a date, we can give them a time frame, typically 3 months or 6 months. If you're looking at endometriosis, then slightly longer course of treatment. If it's a simple ovarian cyst or PCOD or hypothyroidism, even a shorter time frame can be told to them. Along with the remedy, counseling is a must, and depending on the level of literacy of the couple, sometimes our role in counseling is quite detailed. We have to talk about fertile days, we have to teach them about ovulation tracking. This is equally important as giving the right remedy. And lastly, if you feel so, don't hesitate in involving a gynecologist. You won't lose patients. Rather, if you take this step at the right time, you will gain more respect of your patients as well. So when we speak about counseling, what is it that we usually focus on? One is to allay the anxiety of the couple. The second is coital advice, like I said, ovulation tracking, explaining to them fertile days. And lastly, provide clarity of your treatment, what your treatment aims at doing, what kind of medication you'd be giving, and what duration you'd be looking at for follow-ups. Now we come to understanding why there was a need for a new integrated homeopathic protocol. Why did I look towards folliculinum, and why wasn't I just happy with regular constitutional treatment? So there's a couple of reasons for that. First and foremost, everybody wants faster results. As I told you, people start family planning later and they want results, like yesterday. That sometimes the patients can also be quite impatient. Secondly, we see a lot of history of excessive medication, particularly consumption of the OC pills or the hormonal contraceptives. This is a sort of a catch-22 situation because these are patients who have had hormonal irregularities like PCOD, which in modern medicine are treated with OC pills. So they took something that was therapeutic at that time for them, but today it's interfering with their ovulation and therefore conception. So when there's been a history of excessive medication, the original unmodified picture is altered. So in such cases, to actually get the traits and the constitutional symptoms sometimes can be a little tricky. Occasionally, there is a block at the level of the organ. Now, what do I mean by this? This I've seen in some of my PCOD patients where, they start improving at all parameters. The cycles get regular, the acanthosis, the hirsutism reduces. She's lost weight by her efforts as well. But still, after 3 regular cycles also, she has not conceived. In some cases, we've had patients and, when we work with gynecologists, we hear them say that there's excessive IVF failure because the quality of eggs is bad. There's a number of reasons that contribute to that. And when we give our medication, we can also contribute to better quality of eggs. So for these reasons, we looked at something different. We looked to go beyond our constitutional remedy. But when I say new approach or integrated protocol, honestly, it doesn't mean that it's something that I came up with from the top of my head. If I'm looking for something, where will I go? I'll go back to my source books. I'll go back to homeopathic literature and see what the pioneers have done, which I can incorporate today as well. So before I go ahead, I'm going to give you a glimpse of a reference as to where this protocol has stemmed from. And we start no further than the 6th edition of Organon of Medicine. Just to confirm, you can see the slide of Organon of Medicine, everyone?
We can, ma'am.
You can, right? So now it's going smooth. I can just proceed with in this flow. Is it all right?
Yes, ma'am.
Okay, thank you. So as I said, we first start with the organon of medicine, which is often in homeopathic schools called the Bible of homeopathic education, and I definitely agree with that. I would like you to refer to aphorism number 257, where Dr. Hahnemann says the true physician will be careful to avoid favorite remedies. Otherwise, less frequently used remedies that might be more homeopathically suitable, consequently more serviceable to the case, may be neglected. So very clearly, this line that he says, I feel, is apt for some of the smaller and lesser known remedies, because we tend to, come up with polycrest remedies. Even in our hospital OPD, when my students come back with a case and I ask them, what remedy would you like to suggest? It often goes in the theme of polycrest, like Natramure, Kali group, Calcarea group. And that's because you see those prescriptions more frequently. So as Dr. Hahnemann cautions us, we should keep our mind open and we should learn to read little more literature and look for these smaller remedies as well. Now, this concept of smaller remedy, or why I went to a SARCODE, again, the reference belongs to two pioneers and two concepts. One is called specificity of seat, which basically means sphere of action, and Burnett, who put forward the SARCODE therapy. Now, what does specificity of seat involve? This has been highlighted from the time of Paracelsus and was further developed by Bonninghausen in his grand essays. It's also been touched upon by Burnett, and they say the organ does indeed possess not only autonomy but also hegemony. Now, what does this mean? This means autonomy or autonomous, we're all aware, it means independent, having your own independent standing. So here they mean to say that the organ is in itself also an independent state, and it exerts an important influence on the entire organism. Let me take a moment to explain this, because right from first year you've been integrated with the concept of holism and holistic approach in homeopathy. So I don't want anyone to get confused or think that we're going away from that. Yarish, can you mute everyone, please? Thanks. All right, sorry about that. Let us go back to the concept of autonomy and specificity of seat. What I was explaining is that whilst we still stick to our concept of holism and holistic approach in homeopathy, we also give importance to the organ where the pathology exists. So what we're trying to say here is that any organ also has its own identity, and that the effects in that organ contribute and reflect and have an impact on the entire organism. All of you who study from your homeopathic materia medica books, you've always touched upon sphere of action and pathogenesis, right? In fact, even in the exams, you're often asked to describe gastrointestinal symptoms of aloe or skin symptoms of bovista. Why is that? Because these particular remedies have been found to have extraordinary action or preferred action on particular organs. And that's the concept that we're going ahead with. Further, when I speak about the theory of SARCODEs, Dr. Burnett mentions in the book Best of Burnett, where the organ ailing is primary to the organism, use organ remedies in little material doses frequently repeated. So where the pathology lies in the organ, ailing means diseased or where the pathology lies, where the organ ailing is primary to the organism, implying that where the local pathology is more important and exerting greater influence on the organism, you can use organ remedies in little material doses, which refers to our posology and potency. So little material doses means lower potency, frequent repetition. However, where it's the other way around, where the organ ailing is a piece of the pathology of the organism, use the homeopathic simillimum in higher potency, infrequently repeated. Is this clear for everybody, or do I need to explain this? Give me a quick yes or no in the chat box, everybody, if in case this is clear. Did you understand the concept of why we chose this particular approach and what the meaning is? Yes or no? One example. All right. So just to reiterate, as someone's asked me to repeat it, I'll just explain it once more. What we are trying to say here is that you need to understand, obviously, as we know in homeopathy, the entire organism is affected. The patient as a whole requires treatment. What you need to understand is whether it is the local pathology is so severe or there is a block at a particular organ, which the pathology of which is impacting the entire system, right? Sadia has asked for an example that will come up next, and I'm going to integrate that with infertility and folliculinum. So let me give you a very common example of liver pathology, right? I think everybody here knows hepatitis, cirrhosis of liver. In such cases, along with the remedy selected on the acute symptoms for the hepatitis, depending on whether it's infective or non-infective hepatitis, very often a remedy either in low potency or as a tincture is prescribed, which is called Cardus marianus. Now, Cardus marianus is a remedy which contains a compound called silymarin. This compound, you can Google it after my session is over, is the base compound for every liver remedy that exists even in modern medicine. Similarly, in homeopathy, whilst we always give the indicated remedy for liver pathologies, adding Cardus marianus, we have found that the SGOT, SGPT enzymes come down within 48 hours or even as early as 24 hours. So that's another example where the local organ, the pathology in the local organ has been so strong that it has exerted an effect on the entire organism, and we have reversed it with physiological doses of an organ remedy. Is it a bit clearer for you? May I come back to infertility? Yes, was that example a bit better to understand? Okay, super. So let's go back, and now let us come, after we've understood the need for this integrated protocol and the fact that we're going to study a SARCODE, it comes down to understanding which of the two SARCODEs prepared from ovarian tissue should we select. Have you all heard of both Uferinum as well as Folliculinum? They are slightly similar. However, Folliculinum has a more extensive clinical proving where we have as many symptoms to give this remedy as a constitutional prescription as well. That's from a theoretical perspective. In the proving of Uferinum, we have more limited indications, and predominantly most of them revolve around the ovarian cyst spectrum. From my clinical experience, when I was doing my master's in homeopathy, we conducted a research in our OPD over there, where we gave Uferinum in low potency, 30 potency, to adolescent girls. These were young teenage and adolescent girls who were unmarried and who had PCOD clinically verified and presented with irregular menstruation. And we found that giving them Uferinum 30 every morning, empty stomach, throughout the month really helped to regularize their cycles. And subsequently in the Gynac OPD also I have used this protocol where for younger adolescent girls where conception and family planning is not of concern, I use Uferinum. And where we talk about PCOD with infertility and ovulatory cycles, I go more for Folliculinum. Those of you who are practicing, maybe you could also, try this protocol. Dr. Rakesh, Dr. Achal, I see a lot of senior people, Dr. Tanvi, I would like to get your feedback as well. So this is what I have seen in my experience. Now let us come to Folliculinum itself. I'm not going to run through the entire theory, just going to give you an overview, and if you want to know which references for Materia Medica where you could refer, I would definitely let you know. As the name suggests, it is a SARCODE prepared from natural estrogen and one of the more potent forms of estrogen. It has been proved as early as the 1950s, so it's really not a new remedy and it should not be a rare prescription. Very interesting, there's an article by Dorothy Cooper where she says, Dr. Forbister, now Dr. Forbister everyone knows is famous for his proving of carcinosin. He said that he had been using folliculinum in conjunction with carcinosin. Although unhappily he did not get anything to print on the subject, he considered the outstanding indications for its use to be overtiredness with conflict of loyalties resulting in stress. Since that time, says Dorothy Cooper, I have used both drugs extensively and always with benefit to the patient, even if not dramatically curative. And she says that I'm saying this after more than 20 years of work. Now let me be very honest with you. I'm going to share a case where you'll see both these remedies were prescribed, but I had not read this article by Dorothy Cooper when I prescribed both the remedies. Before today's session, I was doing a little bit more research and I was reading up, and that's when I came across this article by Forbister where he says he used both carcinosin and folliculinum in multiple cases. They come very close to one another as constitutional remedies, and that's something that we've always known. But the fact that the person who proved carcinosin also found them so similar, that sort of reaffirms what we have read in our literature. So let's take you through about folliculinum. A short introduction. At the time when this remedy was proved, low potencies of the remedy were used, and it was found to be extremely successful against what was called the hyperfolliculinemia syndrome. Even today, if you look up the rubric hyperfolliculia in synthesis repertory, you will find the remedy folliculinum. Hyperfolliculinemia is not a clinical diagnosis. You won't find it in textbooks of gynecology, but it comes close to what we call cystic glandular hyperplasia. Cystic glandular hyperplasia is a form of dysfunctional uterine bleeding, which consists of anovulatory cycles. Typically, the pattern is oligomenorrhea, that is menses that occur at interval of 2 to 3 months, followed by menorrhagia, that is heavy bleeding, and typically the cycle is anovulatory. So this is where this remedy was introduced, and this is where its maximum utility was found to be. Taking you through a little bit of correlation with physiology. Quick revision of the menstrual cycle. The first phase of the menstrual cycle is the follicular phase, and if we speak about hormonal control, it is predominantly under the influence of estrogen. And it is exactly this line that you can apply to the remedy folliculinum. The remedy folliculinum can be used for the follicular phase of the menstrual cycle that typically starts from day 2 or day 4 of menstruation till mid-cycle. And as the name suggests, it helps in formation and development of the dominant follicle and ovulation induction. If you correlate and if you go into the psychodynamics of estrogen itself, it is said that estrogen has a euphogenic effect which provokes lust in life to get stimulated and meet everyday challenges more readily. Just hold on to this thought. Subsequently, I am going to talk about the psychodynamics of ovarian pathology as well. If you were to correlate it with the process of fertilization itself, it requires the ability for self-abandonment and lowering of inhibitions. Because when one's inhibitions are lowered, when one sort of accepts or enters the phase of self-abandonment and self-sacrifice is when the female body is receptive for fertilization and shifting focus to that new life or zygote, if you want to use medical terms. So coming back to the correlation, primarily estrogen is responsible for sustaining fertility, and it is responsible for the development, functioning and regulation of the female sexual organs. Thus, if there is a pathology at that level, this remedy has excellent use. Whilst I am only highlighting its use in infertility, when you read up on folliculinum, you will understand that it works equally well for premenstrual syndrome as well as a lot of symptoms at the perimenopausal age group as well. Now, coming back to understanding ovarian pathology and some understanding of the psychology behind menstrual irregularities. There are books on this, The Healing Power of Illness. There's a book on biogenealogy where they actually explain the psychodynamics behind pathology of every organ. As we all know, the monthly cycle in a female is an expression of femininity, fertility, and receptivity for conception. During this phase of menstruation, she is completely at the mercy of this rhythm and she has no choice but to comply with the restrictions it places on her, which means that every month, this is a given, right? In most cases in healthy females, it is a given that every month she is going to have this menstrual cycle. In some women, it comes and goes without disturbing them. In some, it disturbs them just with strong premenstrual symptoms. Some have dysmenorrhea. Whatever it be, she has no choice but to comply with it. And if there is a failure to reconcile to this process, to the process of conception, where we have women that have conceived, unplanned pregnancies and they're not ready for it, or they had made up their mind never to have children, but then there's an unplanned pregnancy, it leads to a lot of conflict where she questions her own femininity, and that is the basis of most menstrual problems. In case this is a little too deep for you and you don't want to go into the depth of psychodynamics, the easiest way to remember it is to remember the pathology of PCOS. In PCOS, what do we find? Which hormones increase? Come on, let me hear from you. I'm a teacher, so I'm used to asking questions, right? In cases of PCOD, which group of hormones rise more? Is it the estrogens? Is it? Absolutely, right? It's the androgens, testosterone, SHBG, DHEA. So these androgenic hormones, now the androgenic hormones are associated with which gender? Male gender, right? So your symptoms also, like hirsutism, and alopecia, here what you see is this imbalance between the femininity and the rise in the androgenic manifestation and hormones. So if you don't want to go into the depths of psychodynamics, just remember this one line of pathophysiology of PCOS and you will understand this. Alright, is this clear for everyone? I hope it's not too in-depth for a Sunday evening. Okay, super. So let's go ahead. Basically, if you study ovarian pathology, you will learn that ovaries are affected by any conflict of loss and any threat or injury to survival. Obviously, because the only way of survival of the human species is by reproduction, and those are the only organs that are responsible for carrying the generation forward. So any threat or injury to survival directly affects these reproductive organs. And the conflict of loss directly affects the hormones. As homeopaths, we study the PNEI axis. We talk about the impact of the mind on the endocrinal system and on immunity, and that is now being understood even in modern medicine. There are papers not published by homeopaths that talk about this correlation. Any conflict of sexual frustration or lack of affection, be it physical or emotional in a relationship, directly impacts the uterus and cervix. There's a reference article that I came across which spoke about folliculinum and how it works on adults when they are burdened with various pressures. 3 important pressures that have been described. One is pressure of a person or a group, which is basically presence of someone or a group of individuals that are extremely dominating. Pressure of work, we're seeing that again very commonly in today's day and age, right? We've had people who've been working 18-hour shifts in COVID because work from home had no boundaries. And the third, again very applicable in the post-COVID era, pressure of continued ill health or convalescence. Convalescence meaning slow recovery after a severe infection. So when I came across this article, I realized that it's extremely applicable to what we see today, and maybe, we can start using this remedy a bit more. So let me explain to you a few important themes of folliculinum. First and most important is ailments from domination, where there is a feeling of being controlled, being dominated against one's own will, and because of this domination, which can continue for a long time, they go into suppression, wherein their own feelings and their own desires are completely neglected. Now, when a person has to, comply with someone else who's more dominating than them, what do you think is going to happen to their own tendencies or their own wish? What is that going to happen? Like if one of you were in that situation where, you had to eat what was given to you, you had no meal preferences granted to you, you had to pursue medicine for XYZ reasons, and that too you had to pursue BHMS, how would you feel over a period of time? What would happen to your own choices? Okay, frustration is one, that's good. You'd be suppressed, yes. What else? Good homeopaths, right, who say suppression immediately. There may be a phase of indifference, excellent, yes. Is that all? After you feel suppressed, what's going to happen? Anger, very good. Either the person can go angry and aggression way, or what is the other route? If someone is a little more timid and they don't go down the anger route, sadness, depression, perfect. So you've exactly got the evolution of this remedy. Nothing left for me to teach you. So this is exactly what happens in this remedy. Let us... Yes, Sadhya? Yarish, I think it's by mistake. Can you just mute? Yeah, thanks. All right. So let's understand this flowchart, and I'll show you the same representation in rubrics as well. Ailments from domination for a long time. As you all rightly said, first they go into suppression of their own emotions. And secondly, what happens, develops parallel, is increased sensitivity. Sensitivity to someone scolding them, sensitivity to someone speaking in a rude tone or a loud tone. And later on, over a period of time, when they realize that, anyway, no one's going to listen to me, anyway, nothing that I want to do, I can do. So there's an element of helplessness and sadness. And this evolution can, either the patient can come to you having gone through all these stages, or she may come in any one of these stages. And I've taken the rubrics from synthesis repertory for you just to show you exactly what we spoke about. Ailments from domination, delusion under the influence of a superpower or a powerful influence. That leads to sensitivity, sensitive to reprimands, to being spoken to rudely, which invites sensitive to being offended easily. And lastly, they become sad and they go into weeping. Now look at the repertorial, the sheet here. Which remedy comes exactly touching folliculinum? Which is the first remedy on the repertory sheet? Carcinosin, right? And now we go back to Forbister. Forbister had said that he uses both these remedies. In fact, if you see, the main theme in carcinosin that they also talk about is a strong ailments from domination. So now, is it making sense for you all as to how these remedies come so close to one another, and how we don't have to use folliculinum just to induce ovulation? We can actually even use it as a constitutional remedy. Is it clear so far, everyone? Okay. Let's go forward. Another important theme in this remedy is that they get completely lost in devotion or in relationship. Now, devotion is not only related to a romantic relationship, right? Devotion, I can be devoted to my work. I can be devoted to religion. I can be devoted to taking care of parents. Whatever be the relationship or whatever be the aspect that the folliculinum patient goes into head on, they become completely lost in that. And when they become lost, what happens? Who do they lose? They lose sense of their own self. And this ability this ability to selflessly devote oneself to a task like taking care of a family or to a relationship, again psychologically has been linked and attributed more to females and attributed to estrogens. Have all of you come across a little bit of Chinese philosophy? Do we know about the concept of yin and yang, everyone? So if you are familiar with the concept of yin and yang, you can definitely read that, and that Chinese philosophy also talks about how these aspects are predominantly female. Vignesh, I would love to go into the detail of yin and yang right now, but I think we're out of time. I'll just give you an overview. Yin and yang talks about the union of male and female, yin and yang representing two separate entities, and how that they have absolutely opposite qualities and attributes, and that coming together and that union is what happens in relationships. So you could just read about it. You get various articles, and if you have any doubts, you can obviously reach out to me, and I'm happy to discuss it with you. But we won't be able to go into the details of that. I just wanted to introduce it to you so that you understand why we say that certain traits, there's a common saying, right? Boys will be boys. So why do we attribute so much to gender? It is linked to the hormones, and it can today be explained by science. All right.
Thank you, ma'am.
Most welcome. So here in folliculinum, they lose themselves, and the attempt to compensate is by utmost devotion and selflessness. So this is what happens here. There's a complete struggle, and then eventually there's a loss of one's own identity. And if I say loss of one's own identity, which remedy comes close? Quick materia revision. Which other remedy loses themselves in, especially in a romantic relationship? Alumina has conflict of identity. Definitely all of you are right. But which remedy in row 3 of periodic table? Ignatia, chocolate. If I give you the ailments from, you'll answer in 1 second. Yes, natrum mur. Very good. So natrum mur again comes close in this aspect of losing oneself. And look again at the repertory sheet. Can you see, has the slide changed? Can you all see the clipboard? Yes, can you see the clipboard when natrum mur comes as remedy 6?
Yes, ma'am.
Yeah, so this is how when we study one remedy, we study remedies that come close. So this is about the various themes of folliculinum. The third important aspect is ailments from abuse. This can be emotional abuse, physical abuse, or sexual abuse. I've given you the rubrics for your reference. And the last theme that I'm going to talk about at the level of mind is the PMS. Now, how often have we, while treating cases of PCOD, had patients come to us and say, doctor, my cycle is late, and because my period has not come, I've got headache, I feel bloated, I feel very uncomfortable, listless, no desire to go to college. Have you heard this? Have you heard this from patients who are expecting their cycles, but the cycle has gotten delayed? I have all the symptoms, doctor. My cramps are there, white discharge is there. This is what they say. I'm giving you the patient's language. This entire spectrum is very well covered by folliculinum, and these patients get a lot of relief once the menses come. Please don't sit and give lachesis to every single patient who tells you that they are better when their menses come. We have other remedies like folliculinum, like zincum met for this particular symptom. So let us quickly go through the various rubrics of the premenstrual state. Mind, anxiety before menses, feeling of helplessness before menses, irritability before menses, very, very common. And you see folliculinum is a 3-mark remedy in this rubric. Sadness and weeping before menses, this covers the mind. We also have a very broad rubric in the chapter of generalities. Generals, menses before aggravates, meaning generally everything head to toe gets aggravated, all complaints get aggravated before menses. Now, please draw your attention to rubric number 9. generals, dropsy in general, menses before, only one remedy, and that is folliculinum. This is what we see day in and day out. Doctor, I feel bloated, I've got water retention, I'm due to get my period, but it hasn't come. So you have that reflected in the rubric as well. Other remedies of PMS, which you know very well, pulsatilla, natrimur, sepia, phosphorus, come close, but this is the only one that covers all the rubrics that I wanted to demonstrate for you. So with this, let's move to a clinical understanding as to which conditions and where to use this particular remedy. It is given in cases of PCOD, infertility, and premenstrual syndrome. And in its clinical picture, apart from this, it's also a good remedy for simple or hemorrhagic ovarian cysts, acne, and amenorrhea. Other indications include, as I said, it's good for menopausal complaints as well, delayed convalescence after acute illnesses, postpartum depression, postpartum blues, craving for sugar, wheat, and farinaceous food. Again, a common symptom of PCOD. And in this remedy, as I said, all symptoms are better as soon as the menstruation starts. So this was a quick summary which tells you exactly what we just spoke about. It has a lot of common symptoms of PCOD and infertility, such as alopecia, acne, weight gain despite not eating too much, oligomenorrhea. And it almost seems like this remedy is a mirror image for PCOD and anovulatory cycles. Is this clear for everybody? Have we understood folliculinum and its themes as regards materia medica? Yes, are there any questions so far? All right. So if you're not too tired, should I go through a case in 5 minutes, or would you like me to do wind up and do questions? Does everyone need an evening cup of coffee? Okay. I like your enthusiasm. I will try to be as quick as I can, I promise. So I had just put together the same rubrics, but I've explained that, so I'm really not going to go through that. Let us go to a case. Okay, before that, I want to tell you my use of this remedy. What is my posology recommendation? It acts better in a lower potency. Mostly organ remedies we prefer to start with low potency. Typically, I start with folliculinum 30 twice a day from either day 1, or if the patient is, very uncomfortable and has dysmenorrhea, menorrhagia, then I hold off on the remedy and start from day 4 of menstruation. Continue for 15 days. And you can integrate the constitutional remedy in infrequent doses premenstrually. There are some practitioners who have an infertility protocol to give just 3 doses of folliculinum mid-cycle, day 10, 11 and 12 to boost ovulation. Alright, now I'm going to demonstrate just one case in detail, but I believe in this. Now not reproducibility because I'm a gynac teacher, no pun intended. Reproducibility of results. Just because today you are attending a webinar where I have spoken about, folliculinum for infertility, doesn't mean that that can be the new protocol and I should, put it in the headlines of homeopathic journals tomorrow. We have to be able to reproduce the same result. If we have 10, 20, 30 and eventually, many more cases where this protocol is effective, then we can say that we have clinically verified this. So I really encourage you, if, those of you who are practicing, if you do use this protocol, please let's try and pool together our results so we actually have good amount of data. All right. First case of a 30-year-old female married since 3 years. She consulted us for a complaint of irregular menses since the past 6 years. She was diagnosed with PCOD 1 year ago, and she says, currently, I only get my cycle after taking the hormonal pills for withdrawal. She also mentions the inability to conceive. On taking her history, her menstruation currently lasts for 3 days, is always induced. This is a slightly older case. Last cycle when she visited us was 2nd of February 2017. Complains of mild dysmenorrhea. She says earlier, 6 years ago, she had a very regular cycle of 26 to 30 days with bleeding for 4 to 5 days. Associated complaint, acne, hair fall and weight gain. But the more troublesome symptom for her was a headache for the last 14 years, location temples, sensation of something hammering, or being drilled. Concomitant symptoms with the headache include nausea but unable to vomit, slight confusion and sensitivity to noise during the headache. Headache is worse by sun exposure and fasting, better by rest and vomiting. So what is your diagnosis of her headache? Which type of headache is she described for us? Migraine, fairly simple. And as regards the chief complaint, what is the differential diagnosis coming to mind? Pretty straightforward, right? What do you think is a diagnosis of a chief complaint? Irregular cycles, acne, weight gain and hair fall. PCOD, right? Closest would probably come would be hypothyroidism. Pay attention to family history. Mother CA cervix and past history galactoria. Everybody is aware what is galactoria? I hope I don't need to explain this. Galactoria refers to milky breast discharge in a non-lactating female. And which hormone is responsible for galactoria? Which hormone rises to give rise to galactoria? Prolactin. Perfect. So we must rule out whether she's got hyperprolactinemia because that also impacts the menstrual cycle. High prolactin can also lead to amenorrhea and oligomenorrhea. Alright, great. Generals, craving for meat, more of non-vegetarian diet, perspiration, nape of neck, sleep position, abdomen, and generals, sensitive to light, which is photophobia, again a common symptom of migraine. Coming to her mind, she's been born and brought up in the city of Bombay. She stays with her husband. She has had a love marriage, which everything was quite smooth and that phase of life is quite peaceful and happy. She says, my childhood was good, but I was afraid of my mother as she was very strict. My mother always wanted me to get the first rank, but she says I did not have much time to study because from a young age, I was asked to help out at home and take responsibility of her younger sibling because both parents were working. So she said I was always afraid of my mother, and before my mother used to come home, I tried to finish everything. Other attributes include loquacity, particularly anxiety about her own health. She said a lot of people have told me that my disease is incurable and I won't get pregnant. So that was the fear which she had. Desire for company because she was very friendly and extroverted. So case analysis, I've taken the symptom in patient language and converted it into the rubric for your reference. But I think we can skip that and directly go to the repertorial sheet. So as you see here, the symptoms taken were ailments from domination, anxiety about one's own health, loquacious. Instead of loquacious, I took the rubric communicative, which comes closer to extroverted. So extroverted people are talkative and friendly, but unlike loquacious patient, they stick to the subject and they don't go on. Like let's say they have a full stop and you can also get a word in. Mind, early responsibility. Now there's a broad rubric for this. Taking responsibility seriously early and responsibility in young is only one remedy, carcinosin. Other characteristic particulars include head pain, fasting, head pain, sun exposure, menses absent, tumors in the ovary, which is the rubric for the polycystic ovaries, perspiration, nape of neck, desire chicken and desire meat. As you see, the remedies that come up include phosphorus, sulfur, calcarea, carb and natrimum. So working out on the case, on examination there was acanthosis. Investigations fresh were not asked because she said she has her sonography and blood test done recently, so we asked her to bring it along. Diagnosis was primary infertility because of PCOS and migraine. Now we come to the management plan. So this is something that I follow. Even in clinic, I may not write it down, but definitely it's something that I work on. Always have a therapeutic plan and a non-therapeutic or a non-pharmacological plan, which includes your dietary advice, counseling, home remedies. You know, if you're certified in nutrition, then diet plan. So the therapeutic plan was the focus and the treatment to be directed towards regularizing the cycle and ensuring that the cycles are ovulatory. Patient was weaned off the OC pills because, as you know, oral contraceptive pills suppress ovulation. So immediately weaned off that, and concept of fertile days was explained to her. Now, although the remedy carcinosin came 11th on my repertorial sheet, as you can see, that's the remedy that I selected because it covered the core theme of the patient. What was the theme? Early responsibility, looking after her younger sibling, and there wasn't that much of an age gap between them. Ailments from domination with strict parents, anxiety about health, loquacious patient, and certain generals like sleep position, abdomen, craving for meat, which also fit the remedy. So prescription, carcinosin 1M. Now please go back to the theory that I spoke about earlier. Indicated constitutional remedy, high potency 1M, infrequent doses, that is 3 powders. She was asked to come for a follow-up within 15 days. So from the first follow-up itself, she reports a reduction in both intensity and frequency of her headaches. March itself, she gets a natural cycle. Because she couldn't find her old reports and because infertility was her main concern, I directly sent her for a follicular study, which is a type of transvaginal sonography to check growth of the dominant follicle. So this showed multiple small follicles but no dominant follicle, indicating no ovulation. Subsequently, we continued with our same protocol, carcinosin 1M 3 doses premenstrually and folliculinum 30 because her report showed anovulatory cycles. So after 6 months of regular treatment and regular cycles but no conception, I asked her to again go for a follicular study because by this time her migraine was much better, she'd lost weight, acne was better, cycles were spot on regular, no reason for her not to have conceived. So I thought, let me repeat the follicular study, and if she's still got anovulatory cycles, we need to either change our medicine, involve a gynecologist, and see what to do next. So to share the reports with you, is it visible for everyone, the reports? I'm going to just try and zoom in. Can you see both the follicular study reports? Okay, super. So let's go here. You can see the dates, March 2017, LMP 4th March. So immediately 2nd Feb was an induced cycle, 4th March first natural cycle with homeopathy. Right up to day 19, there's multiple small follicles with no dominant follicle. Endometrial lining is good at 10.5 mm. Repeated this in August after the July cycle. Here, can you see on day 14th, what do you see in the left ovary? Can you notice that there is a dominant follicle of 18.5 mm? So here, now, once the dominant follicle reaches anywhere between 18 to 20 mm, I'm confident that it's going to rupture. In most cases, that's the adequate size. Now, unfortunately, this patient, she could not report for her next date. You can see she was called on the 14th for some personal emergency. She could not go. But in that same cycle, she has conceived. She does not get the subsequent period. I get her beta HCG done, which you can see is 78,000, directly falling in the range of pregnancy. Intrauterine pregnancy also, equally important. So just to share a testimonial with you after taking the patient's consent, she was very ecstatic and she just wanted to send me a message to say thank you. So this is all, well and good. I was very happy. But now, since all of you are going to, either practicing or going to be practicing, I want us to discuss a few things here. What if we had only given folliculinum and not carcinosin? Or what if we had only persisted with carcinosin and not folliculinum? Would you choose only one remedy, and if yes, which one? And now after studying folliculinum in so much detail and understanding that this remedy also has a theme of domination, do you think only folliculinum would have helped? I would like to hear your thoughts. Anybody would like to unmute and share their thoughts? How would they approach this case? Or you can type it out if you don't prefer to speak. What do you think?
Ma'am, in my opinion, basically I'm not a medical student. I'm not, but whatever I saw the session as of now, I will say that carcinosin is a better option rather than folliculinum, because the reason is, as you said, that it has many disadvantages, 3 doses and all, and carcinosin has a better effect than rather than the latter. So I feel that carcinosin is the better option, in my opinion. I'm not from medical background, but whatever session I saw, I felt that right.
Okay, thank you. It's nice to see non-homeopathic people also contributing. Anyone else with either studying experience or practice experience? Sheetal says constitutional is easy. So Sheetal, only carcinosin or both? Can you be a little specific? And anyone else? Any other opinions? Okay. Vinny says she agrees with what I have done. That's the best part about being a teacher. Sometimes students will say both. But please don't say both just to please me. Okay, so we have a mixed opinion. We have a lot of people that say both. We have Sadhya, we have Dr. Ajay, a lot of senior people also who say both. Priyal says folliculinum is also working as an intercurrent or anti-miasmatic. So yeah, the reason why I agree with all of you and why I would still, given a choice, think that both remedies, because let's say that carcinosin was needed for multiple things. Don't forget, carcinosin is the one which induced her cycle. First prescription I had not given folliculinum. So carcinosin is the one which improved the migraine as well as the induced the natural cycle. So definitely that prescription was needed, and as you all have said rightly, the constitutional infrequent doses works at that level, at a different level, because we've included a lot of the understanding of the mind as well. Folliculinum worked possibly to convert from anovulatory to ovulatory cycles. So this is the reason. See, we should always have justification. We shouldn't start, celebrating our victory and one good case. And I'm not going to go into the other cases, but I just want to share with you, that we have various other cases where the same protocol has worked. So this is of a 32-year-old female, married since 5 years. So her LMP when she visits us is 1st of January 2018. I'm just going to skim through it. She also has fibroadenoma. One second. Sorry. Yeah. She also has fibroadenoma. She has PCOS, and she has hyperandrogenism. Okay. Now, in this case, she visits us in early May, where she'd already consulted a gynecologist for inducing the menses because it had been 4 months of amenorrhea. So at this case, I have given her pulsatilla 1M when she visits us in middle of May, because she's past the follicular phase almost. Her LMP was 5th of May 2018 after taking OC pills, and she comes for follow-up on 14th May. So she's crossed relatively. The follicular phase is almost at the end, so I just gave her constitutional remedy. She reports saying she feels the size of the fibroadenoma is reducing. And we ask her, she's been on SL, that is Saclac. We then ask her to start folliculinum when she gets her next cycle. So again, pay attention here. It's pulsatilla 1M, and I waited to see that she gets a June cycle on time and then told her to take the folliculinum. Patient was asked to get a follicular study done in the next cycle, which she did not get done because I think she conceived in that same cycle. Yeah, LMP 6th of June. So just 1 month. She's come to us in May. We've treated her with this protocol. Immediately UPT is positive, and we involve the obstetrician, and we also treat for her MSS gravidarum. Similarly, third case, some of you who are in the audience would have seen these patients. This one is from our hospital OPD only, lockdown case. Again, 32-year-old, married since 3 years, LMP 22nd August. Again, now here LMP August, no cycle till November. This is another aspect that I want to touch upon. Sometimes these patients come with oligomenorrhea, no cycle for 3.5 months. In my experience, these cases are the instances where sometimes you have to involve the gynecologist, because that one cycle you may need to give OC pills to induce a withdrawal. And moment they get the cycle from day 1 or day 2, that's the best time to integrate your homeopathic medicine. Same thing we have done over here. She had been to her gynac, she took the withdrawal medicine and she got her cycle in December after taking the withdrawal. End November she's taken it, and then she's got her cycle on 17th of December. Gave her folliculinum in the first half of the cycle and told her, report to me after your next period, or if you don't get your next cycle by end January, do the UPT. So exactly that, 30th Jan she does the UPT. Subsequently, you know, everything, it's intrauterine, it's a smooth pregnancy, she's had the baby, but I just didn't want to go into the specifics of that. So just to give you a gist of 3 cases, there are many such where we've used this protocol, and I'd shared this in another webinar that I'd taken for a group of homeopaths in Singapore, and you know, one of the doctors also wrote back to me saying, thank you, I use the same protocol. So this is what I mean when I say let us pool together our knowledge and then, you know, take it from there. So let us sum up what is the protocol? The protocol is the similinum or the constitutional remedy is prescribed infrequently, and folliculinum has been prescribed in low potency for the first half of the cycle. And as you see, all patients were cured in as early as 1.5 months they've conceived, and the first case it took 6 months of treatment. So that's what I wanted to share with you. If I were to give you some takeaway messages for spending your Sunday evening with me, I always stress on aphorism 1, 2, and 3. Aphorism number 1 is where Dr. Hahnemann says, our only mission is to ensure our patients get relief. And aphorism 3, he talks about the knowledge of disease, which I believe is extremely important. One has to know where our role starts and where our role ends. And that involves knowing the diagnosis. And lastly, to all of you that are still students, learn all approaches. Any teacher, any mentor, we are all still learning. I myself have attended a seminar in the morning today, and today in the evening I'm conducting one. So, learning never stops. We are still students even though we are teachers. So learn from everyone, keep, just collect. It's like collecting trump cards. Collect all the cards, and then when the patient comes, you have all 52 with you. You know what to deal out to with which patient. So with that, I'm going to end. Thank you all for listening to me so patiently. I definitely owe you a good cup of coffee, but if you have any questions, I'm happy to answer them. Okay, Dr. Achal said about the first case, both remedies are covering a similar essence, so they prove to be complementary. That's a good thought as well, right? Maybe we need to explore the remedy relationship, whether folliculinum completes the action of carcinosin. So that's a good thought. Dr. Ajay says, can we use 2 SARCODEs at the same time, for example, folliculinum and thyroidinum? Definitely, Dr. Ajay. In fact, patients who have, we have another patient in our OPD who we are just treating. I'll just give the name because I think some of my students are here. Patient whose name is Priyanka. She had hypothyroidism, PCOD, and hyperprolactinemia. So you can understand multiple pituitary dysfunctions. So she was given thyroidinum 3x every morning and folliculinum at the start of the cycle, as we've discussed. Priyal, yes, folliculinum after menses, in the sense from day 3 or day 4 of the menstruation till mid-cycle. That's when we expect ovulation. And pre-menstruation, we give the constitutional remedy. That's what I have been following so far. Did you understand, Priyal? Okay. Any other questions? You can unmute also. I'd be happy to hear from you and see your face. Okay. If you don't have any questions, we can wind up. Thank you, Dr. Rakesh. Thank you, Shriya. Thank you, Yarish. And if anyone else who I'm supposed to thank and has helped, then thank you from my side.
Thank you so much, ma'am, for the wonderful session. I would now request Dr. Rakesh Gupta to say a few words.
Hello.
Good evening, Dr.
Good evening
Rakesh.
to everyone. Good evening, Dr. Kanika. It was a well-rounded session, and I can really vouch on that I've used folliculinum along with constitutional in my practice in a lady who was almost 42 years of age with AMH as low as 0.3. So she was almost given a opinion of adopting because she was elderly and almost reaching her menopause. So many of the gynecologists suggested that there is no possibility of conception, and it was a surprise to me also. Her constitutional was lycopodium.
Okay.
So in her case also, domination was the theme. I mean, I'm now trying to understand from this case which Dr. Kanika said. Domination was the theme, and lycopodium was covering the in and out of the entire case, and folliculinum during the different phases of menses in an infrequent repetition was used, and she conceived within 3 to 4 months of treatment.
Wow.
So it was really a surprise case, and it was a case common between me and Dr. Usha Lukanwala. She's very senior gynecologist in our area, so she was also surprised. So this is one thing. So understanding domination, carcinosin, folliculinum, lycopodium, sepia. These are few drugs which come, and all these drugs have good role in cases of infertility, whether it is primary or secondary. I have a lot of cases with bad obstructive history where they have, inability to retain the conception. Either they are having underlying past history of torch infection, or they are autoimmune ANAs positive. And these cases have responded well in combination of sepia coming up as constitutional, and in those cases we had used sickle core as one of the important drug. So infertility overall at this juncture, I will say, as a homeopathic physician, infertility is a huge area where homeopaths can do a great work, and it is a field where we can give hope to hopeless parents, hopeless couples. So this is what, it's a huge area where we all can practice. Overall, it was a very nice session and I liked it. And this was one session which was, maximum audience in your session, Dr. Kanika. As I have said earlier also, you're a great orator and really happy to have you on this platform. Thanks a lot.
Thank you. Maximum audience is because audience is good. It has nothing to do with me. They are sincere and they've decided that Sunday evening we will spend learning homeopathy. So I think kudos to them. So thank you everyone. Enjoy the rest of your evening.
So I would like to tell Dr. Sagar Doshi to give a vote of thanks.
Thank you. Thank you, sir. And sincere thanks to Dr. Kanika, ma'am, for the valuable session, detailing this very frequently encountered clinical condition, and also detailing the therapeutic applications of folliculinum, which we can use in our day-to-day practice and also in the OPDs. I would also like to thank Satva Charitable Sanstha for giving this platform to nurture and help budding homeopaths by giving them a new direction. Lastly, thanks to the audience for being such patient listeners. Hope you all enjoyed this session, and we will be having many such sessions in the near future. And have a lovely evening, guys. God bless you.
Thank you, Sagar.
Thank you, ma'am.